All right, welcome everyone to our Talk Infusion webinar on the NHIA comments on the calendar year 2027 home health proposed rule, as well as some other important updates that we have for you today. So appreciate you taking some time out of your day to join us. All right, Bill, you are advancing slides. There you go. So we wanted to actually start off with some good news. Many of you probably remember a webinar we did a couple months ago on a proposal by CMS to revise the units and descriptions for HCPCS codes for IG products. You can go to the next slide. And NHIA put out pretty robust comments on why CMS should not pursue this change. It would be a pretty substantial lift for everyone in the healthcare system, from payers to manufacturers to providers, to really pretty much anyone who touches a claim for IG, to make this change in the time frame that they had proposed, which would have been January 1. So NHIA, we did an open access webinar. We invited manufacturers and other stakeholders, payers, everyone to attend. We educated a lot of our partners on this proposed change and what it would mean in terms of the work to make the implementation happen. And ultimately, our message was, this is kind of a solution looking for a problem. We really didn't see that there was any good reason to make such a significant change to the coding for IG, and laid out a whole bunch of reasons on why it would be operationally challenging. And so the get to the point here is that CMS actually reversed course as a result of all of the stakeholder feedback, and at this point will not be deleting the current 500 milligram codes for IG products and replacing those with new either 100 or 200 milligram codes effective January 1st. So they have always left the door open to come back and revisit this in the future, and may do some revisions to the descriptions to remove things like route of administration, since some products are used both sub-Q and IV. But other than that, we're really pleased with the outcome here. We're commended CMS for taking our feedback into consideration. You will note 2 new products that were approved during this time and did receive 100 milligram units and descriptions. So those apparently will be maintained and not reverted to the 500. So there will be some outliers here that have different code or different units. But other than that, really appreciate everyone who chimed in, wrote comments to CMS, and helped kind of put this on the back burner, because it would have just resulted in a lot of administrative work for everyone, and not really had any real clinical benefit or cost savings benefit. Bill, anything I missed on that?
I was looking to chime in, but you covered it very thoroughly. I think it's a big win, and super happy that they received the volume of comments that got them to listen. A lot of times it's hard to get CMS's attention, but I think the diversity of the backgrounds and companies that submitted comments probably had an effect. And this would have affected more than just home infusion therapy. It would affect anybody that bills HCPCS codes for IG. So physician offices, hospital outpatient departments, and I would not be surprised if there was a volume of comments there as well.
Great. All right, I want to move on quickly to the home health rule and the comments that NHIA will be submitting shortly. We did make our draft comments available on our website, so you can take a look at those. And I'm not going to review the home health proposal. We did do a Talk Infusion webinar when that first came out, so you can go back and look at that recording if you want to revisit what was actually proposed by home CMS. But this was the rule that will implement the Joe Fiandra Access to Home Infusion Act. And there were several things in there. And I do think that there are some folks out there who are somewhat misinterpreting what this policy does. And so I think it is really important to understand the limitations of the policy in the first place. generally speaking, this just builds on the existing pump requirement for DME POS infused drugs. And it's important to understand this is very limited. So the first thing I would say is that CMS did a fairly good job and got some things right in terms of how they approached this. They were consistent with what we expected. They took a narrow approach to the policy, and we just have some minor comments to clarify. But generally speaking, they did offer a definition of a healthcare professional, a definition of an RN, and they are excluding LPN and LVNs from being able to be used to satisfy this policy. And that's consistent with how home infusion is offered today for these types of products, which are largely going to be biologics. They do say it requires an on-site presence to administer supervised drug administration. Again, not inconsistent with how these are already offered in our industry. And then the one area where they probably went further than the legislative text, which says basically a drug has to be administered at least 12 times per year to be eligible for this policy. They're going to define that as once a month. And that is very significant because there's a lot of variable dosing schedules out there. And they're basically saying, we're just going to refer to the labeling to determine if something is eligible for this benefit. And the labeling must specify dosing at least once a month, every 4 weeks, or more often than that. So drugs that are administered more often than once a month would be eligible. Anything less than once a month would not be eligible if they finalize this proposal. So we tend to agree with that approach. We think it's a reasonable way to determine eligibility. If you think about the alternative of just saying, well, as long as you can maybe get the physician to attest to 10 to 12 doses a year, it could qualify. That leaves a lot of, concern for maybe claim denials and things like that, and more administrative burden on you and the physician to qualify patients. So we tend to support that proposal. Couple things we recommend are more like just needing CMS to go a bit further. One is the need to tie the pump to a clinical need and not infusion rate. They don't really say how they're going to determine whether a pump is required for these. Our recommendation is that it be in the FDA approved labeling that a pump is not necessary. And then again, we do agree that there's no minimum or maximum number of infusions required to be administered. Again, the criteria for eligibility would go back to the prescribing information. So as long as the prescribing information says that dose is needed every month or every 4 weeks, if the patient stops after 1 or 2 doses, it's not going to mean you're not going to get paid. The other thing they don't do is crosswalk the DME POS program to the HIT services benefit. And HIT services are instrumental to these products because they have to be administered by a healthcare professional, but they're not clarifying how they're going to make these drugs eligible, where they'll fit into the HIT services. So we're asking for further guidance there. So that's kind of our comments in a nutshell. Happy to answer questions. If you do have questions today, please put them in the Q&A, not in the chat. We're happy to kind of answer questions. Our comments will probably be officially submitted the end of this week, but if you have other feedback for us that we need to incorporate or things that you think we should clarify, we're happy to take more input before we finalize. Anything else to add, Bill, on that?
I would just say we have shared our comments, our draft comments. We are looking for feedback. If you review those, whether it's feedback around Fiandra or the topic I'll be addressing, program integrity, fraud and abuse, and kind of enhancing the authorities around fraud and abuse and enrollment, please share them with us. We are planning on finalizing them in the very near future, and I think submitting it as early as next week. They are due by the end of August. And if you haven't seen the comments, there is a link on the first slide. At the bottom of the first slide here, which we'll be sharing, there is a link to NHIA's draft comments. Let's see, I'll go back to that slide. Here at the bottom of the title slide, there is a link to NHIA's draft comments around the home health rule. All right, Connie, one more slide. I think about HIT. I'm happy to cover it if you're on to something else.
No, go ahead. You can go.
One of the reasons we thought it was important that CMS map to HIT services is that there is very little involvement, enrollment, participation in that benefit as it exists now, to the point where geographically, if they were to approve healthcare provider or healthcare professional administered drugs, um, access to those drugs would likely be very limiting. It could also be a catalyst for new, different people to enroll to become HIT service providers. So there's really some information here about how that benefit has rolled out to date. There are only 64 providers nationwide dispensing oncology drugs. They don't specify what type of drug, but there are three uh, categories of HIT services. One is chemo oncology, one is subcutaneous, and the other is everything else. So your inotropics, foscarnits, things like that, pain management would all fall in that catch-all category. Um, Based on the latest report, 7 of 73 total organizations that are enrolled in the HIT benefit provide more than 50% of overall visits. Um, so you could just see there 7 nationwide provide more than 50% of the overall visits. The participation is really low. We don't see this expansion of the DME benefit really expanding access. We don't anticipate they'll be adding any new drugs initially when this becomes effective, which is April 1st, 2027. So that's the timeline. As far as the home health rule in Fiandra goes, the comments are due by the end of August. And then we expect around Halloween to see the final rule. And that's where they will have response to comments and have some final direction that they will surely then be sharing with the DME Max to update the external infusion pump policy to incorporate healthcare professional administered DME drugs. So that's the timeline we're working with. So if you could provide us with any comments you have so we can consider and make modifications to our comments, and then stay on the lookout. We'll continue to educate folks as this continues to roll out. And from an education standpoint, our conference is just prior to the rollout of the benefit in 2027. So we're in March and it rolls out April 1. So we're working on getting the DME Max to provide education, just kind of looking forward on how Fiandra rolls out. So the home health rule also includes a number of program integrity enhancement proposals that would increase authorities to around enrollment and revocations, stays of enrollment. So it's more important than ever to protect your PTAN. Getting one can be difficult. It's more difficult than it has been in the past. They've recently modified some rules and details. They've increased the frequency of site visits, the frequency of accreditation. As you know, if you work in this space, has gone from every 3 years to every year. So there's a real focus by the Trump administration on fraud and abuse, and they're putting different things in place to minimize that and to minimize it up front as they're vetting new suppliers. And then they're kind of closing the door on any new suppliers right now as they weed out the bad actors. So the moratorium, and this isn't on the slide, but I'm kind of giving you a backdrop. There is a moratorium on a moratorium currently in place for a subset of DME providers. And that is a 6-month moratorium that goes through August 27th. It's possible that it will be extended. It's very possible that it is lifted and not extended. for reasons of the rollout of competitive bidding and the way they counteract and intersect with each other. They've got to let people enroll in order to bid. So I expect that that will be done August 27th, but when we know more, we'll share more. So as part of the home health rule, there's even more authorities that are proposed. And I have a couple listed here on the slides, but overall, NHIA's comments are that we support CMS's program integrity objectives and urge the expanded enrollment denials and revocation authorities be narrowly tailored to intentional fraud and abuse, supported by objective standards, allow for cure periods for non-material deficiencies, and provide meaningful appeal rights. NHIA strongly opposes revoking enrollment based solely on provider geographic proximities, and I'll get into what we mean by that. But of course, we support booting the bad actors while maintaining patient access. And the only way patients have access is through providers enrolled and their ability to provide services and bill for those services. If they can't bill for them, they're not going to provide them. So it's kind of walking that fine line of keeping the good in and getting the bad out. So the affiliations reporting, if you're familiar with the 855S, which is the DME enrollment form, there's an area where you have to identify your managing employees. And your managing employees are people that have a vested interest in the company. Could be the board of directors. It could be anybody with ownership over a certain percentage. And there's certain things that you have to go through and attest to, whether it's fingerprinting. They can't be excluded or barred from the Medicare program based on a past violation. And what they are proposing is expanding that vetting and those checks to people beyond the managing employees, to people that you worked with either directly or at arm's length on marketing, finances, managerial, or ties to the beneficiary, and they don't define what any of those actually mean. It's very, very open-ended, and that could be very, very difficult, if not impossible, for a provider to collect certain information on all these other entities. So our comments are to not move forward with that, to provide definitions, and from a look back period, not to look back any more than 10 years. They're talking about lifting the look back period altogether. It's currently 5 years. So that's one we strongly oppose. The other is the geographic based enrollment risk. And frankly, here, what they're looking at is home health in Minnesota and the number of providers of home health providers that were all located in the same building or the same block, and some issues that they had there. So their proposal is to revoke based on proximity to other providers. And they don't define what that proximity is, what the number of providers are, what the services that need to be provided are. I will say that all of these program integrity pertain to not just DME POS, but any Medicare enrolled entity. So whether it's home health or HIT services or a pharmacy on the Part B benefit, physicians, it's applying to all. And when it comes to the proximity, they can revoke without notice. They can also deny enrollment and make you not eligible to enroll for X amount of years just based on geography. So our stance is that you shouldn't be rejected based on geography alone, that it should require objective criteria, allow people a cure period, And the other thing we detailed in the comments was the fact that a home infusion pharmacy with a single location can be enrolled in a number of different programs, Medicare programs, as various supplier provider types. So for instance, you could be enrolled as a DME supplier. You could be enrolled also from the same location as an HIT services supplier. You could be enrolled as a mass immunizer. You could be enrolled as a pharmacy on Medicare Part B side of things to dispense Factor and a handful of other drugs that are covered there. So depending on how they look at a location, it's really important that they're able to differentiate that, because there's not 5 different people at one location. It's one provider providing lots of different services. Some other things that we commented on, and I didn't detail them all in the presentation, but retroactive revocation, and I understand that's something that providers are dealing with right now. In the past, if your PTAN, if your billing number with Medicare was deactivated, it was from the time the infraction was noticed forward. It didn't go backwards. So now, if, for instance, you don't have a surety bond on file, and you haven't had a surety bond on file, even if you have one, if you haven't provided it to the National Supplier Clearinghouse, and it was 6 months ago or a year ago, they're going to retroactively process that revocation, and they're going to take monies back. And until you cure it, you're not going to get those monies back. So we asked that retroactive revocation should be reserved for material violations involving fraud, abuse, and intentional misrepresentation, should not apply to reporting errors, and there should be a cure period. And really, that kind of statement applies to pretty much everything that they're proposing for new authorities. Make it targeted. We support their attacking fraud and abuse. We did comment on enrollment moratoriums. We think their approach should be much more targeted versus just a blanketed moratorium around enrollment. And those moratoriums and some of these changes can really affect changes in ownership and chows, because in addition to a new site, you can't process right now a change in ownership. So that can affect M&A. It can affect expansion into other areas that very well may need services that are geographically remote, or there just aren't any other providers there. Comments are due August 31st. As I said, we expect the final rule in the fall, and we'll keep members posted. Please review the comments. If you have comments to our comments, you're welcome to send them to Connie and or I'm happy to take those. And one other thing I wanted to provide an update on. So that's the home health rule. This has to do with the recent CMS IPAI 2028 draft guidance. And what IPAI 2028 draft guidance is all about is the Inflation Reduction Act drug negotiation for the drugs that will be implemented in 2028. So that's what IPAI 2028 is all about. And this guidance speaks to Part D processes and also Part B, as in boy, processes for the first time, because in 2028 is the first time that any Part B drugs are identified for negotiation. So I'm going to start with Part D as in dog and the way the process has worked. CMS released a standard default refund amount. This is the amount that the drug manufacturer sends to the dispensing entity or the pharmacy that has dispensed a drug subject to maximum fair price. And there's only a handful of drugs right now that are in the home infusion space that are infused. But that calculation for all Part D dispensed drugs, this is the CMS standard default refund amount. This is their recommendation, is WAC, wholesale acquisition cost, minus MFP, maximum fair price. Maximum fair price is that negotiated price. And these are all by NDC number per 30-day dosage. And CMS has published all of those dosages. And when you submit a claim to Part D, it's an NCPDP claim. It's got the NDC number on it. The manufacturers aren't required to use the standard default refund amount, but if they don't, they have to justify that they're using something different to CMS. So right now, at least for the infusion drugs, all the manufacturers are using that standard default calculation. What the rule says in general is that the maximum fair price must be made available to the dispensing entity. And they can do that one of two ways. They could do it up front. They can allow you to buy a drug at or below maximum fair price, or they could true it up on the back end. And that's what they're doing through this effectuation and this payment that comes from the manufacturer that trues the overall payment up to WAC. So the process flow currently is that the dispensing entity dispenses the drug, submits the claim to the Part D plan. The Part D plan identifies that as a maximum fair price negotiated drug. There's a separate entity, the Medicare Transaction Facilitator, the MTF, that we've talked about on many calls, that verifies and sends the data to the manufacturer so they can process the refund. And that refund is processed about 25 to 30 days after the dispense, and we've referred to that as float. And it can be a significant amount or percentage of the overall reimbursement. You know, you're going to get paid two different amounts: one, the maximum fair price, and then two, the standard default refund amount, or the refund from the manufacturer 30 days later. I've sat in on the stakeholder calls right along that CMS has put out regarding the rollout, implementation, and then the data that has been coming through the MTF. And the process is working. They're processing tens of millions of claims and about $80 million a day in the refunds. So it is a significant amount of money. And that's money that everybody is waiting 30 days for. So financially, you got to work through your cash flow. 340B claims are not subject to a refund. And that is where I hear the most complaints, complications, issues within Part D, is that the manufacturer isn't paying me, but this wasn't a 340B. How do you true that up? There is a process for it. There's a company called One Beacon that's an intermediary that deals with good faith resolution process. But that's what I hear over and over on the calls. Now, in the guidance, CMS is looking to codify how they've rolled out Part D over the last couple of years, which means this would be how they do it into the future for Part D, which is important because that standard default refund amount they're looking to codify at WAC minus MFP for Part D. Now I'm going to move to Part B. In 2028, 6 of the 15 drugs selected for negotiation are Part B drugs. They're listed here, and many are provided in physician offices, hospital outpatient departments, and also via home infusion companies. When provided in the home, they may not be Part B. They're likely Part D. But these are Part B drugs subject to negotiation that will have a MFP assigned in 2028. Entyvio is one we see quite a bit in the home. There are others. So This draft guidance gets into some details and asks some questions and asks for feedback about how they're going to deal with Part B effectuation. Now, Part B billing, buy and bill, is very different than Part D. Part B is all ASP based, all HCPC driven. So one HCPC code could represent multiple manufacturers, multiple drugs, size vials, concentrations. And when it comes to an NDC, that is very specific to that specific vial and that concentration and that dosing. So they want to extend the MTF, the manufacturer transaction facilitator, to Part B. And they are debating and asking for feedback on how to do that calculation, because it is not as simple as WAC minus MFP, because there is no ASP WAC, because there are multiple items in that HCPC bucket. So what they've laid out is 4 different options. I've got them labeled here. A1, I'm sorry, got it labeled here. 1A, 1B, 2A, 2B. And they're looking at basing the price either on WAC, that's number 1, or on ASP. So what that means is that they're considering the standard default refund amount for Part B to be WAC minus MFP or ASP minus MFP. And they've got those 2 options laid out here, each in a different way. Right now, Part B buy and bill claims are not required to have an NDC number on them. So what they're considering is creating HCPC codes for MFP price negotiated drugs. So if a HCPC includes both negotiated drugs and non-negotiated drugs, breaking that out so that the drug has its own unique HCPC code. They're also considering using the average WAC. This is 1A, the average WAC across NDCs in HCPC to get a weighted ASP volume. So in that case, they'd use the weighted average WAC minus MFP to get to the standard default calculation. In number 2, using the WAC for the actual NDC, and that would require providers to add the NDC to the claim each and every time, not just the HCPC, but the NDC number to the claim. If they go with the ASP basis reporting, they would use the average ASP across NDCs weighted by average sales volume. And the other option is to use the weighted average ASP using NDC utilization on Part B claims. And that would require submission of NDC within that Part B claim. So it is possible that there's going to be a different standard default refund amount for Part D than for Part B. And they definitely have some work to do so that the MTF can process these claims, because they are so very different than NCPDP claims. It makes my head spin, but I want to just lay out what it is they're considering. It may drive incentives. I know the way they rolled out Part D is they made it mandatory for all entities to enroll in the MTF. Does that mean they're going to make it mandatory for all Part B buy and bill folks to enroll in the MTF? And that enrollment includes financial data processing, because what the MTF does is it's a conduit for information. They identify a drug as being subject to maximum fair price, and as a result, that information needs to go to the manufacturer, and then the manufacturer needs to process some type of refund to ensure that that physician, in this case, this new dispensing entity, is able to be made whole. Now, 340B has been an issue in Part D. Most of 340B happens through Part B channel. I mean, the vast, vast majority. So they also are proposing that for beginning in 2027, that the negotiated drugs follow a different 340B process, that the entity buys the drug at regular price and then submits a claim or data that this was subject to 340B so that they can differentiate and have visibility into what actually is 340B and what isn't. What a manufacturer doesn't want to do is sell a product at 340B and then pay a refund based on something other than 340B, that double dipping. So I think they've got a lot to work out with the transparency in 340B in order to make negotiation and effectuation work properly in Part B. I think that's what I've got.
All right. We do have some time for questions. If you want to put in a question in the Q&A, we got one that I was able to just type an answer in, but I can maybe read it just in case people are thinking about their question right now. Somebody just asked about the Fiandra policy, meaning just that if a patient's receiving an infusion every 6 to 8 weeks, so more basically not every 4 weeks, those drugs would automatically not qualify. If they finalize the proposed rule the way it is right now, that's correct. So the dose, and it all comes back to the prescribing information, not how the drug is actually used. So the prescribing information drives coverage. And it is important to note that CMS did indicate in the rule that I don't think they really said this is the only drug that will qualify, but throughout the times that this has been proposed, they have cited Onpattro as their kind of case example of a drug that meets this criteria. And we have kind of done our own research to see how many drugs do we think could satisfy this criteria. The most we could come up with was maybe 2 or 3, and that would depend on how lenient CMS is on the pump requirement. So again, that policy, while there are lots of healthcare provider administered drugs that are every 4 weeks, not all of them require a pump. And most of them don't require a pump. And so the pump is still the driver of that benefit, and that's what's going to limit how many drugs can enter the benefit using this criteria.
Yeah, Connie, I know in the past we were asked if IVIG could get captured in this, since it is health care provider administered or professional administered. And CMS is on record numerous times stating that it does not require a pump.
Correct. All right. A lot of information, a lot to digest. If you're one of those providers that bills Part B in an infusion center kind of model, this is really important for you, but it impacts everyone because the drugs that were selected for B negotiation, we're going to be seeing those negotiations in D as well.
Yes.
Yes,
Yes.
well, so that's a different question, but Entyvio is one of the drugs that will be negotiated and then be impacted by this effectuation process. And I think we haven't put our comments down on paper yet for this, but I think our comments will say that they need to maintain WAC as the standard default benchmark for effectuation when the drug is in D, even if it has a different effectuation in Part B, because we have different purchasing, power behind pharmacies and then you do physicians, et cetera. And so it's okay if those two things are different. What we wouldn't want is then to allow effectuation to ASP for Part D drugs. So that is something that we're going to be ironing out probably in the comment process. I think there was maybe a question put in the chat. Does Entyvio infusion require a pump per CMS? My understanding is it does not. I'd have to go back to that package insert to see, but I don't recall Entyvio meeting our criteria when we did our research. And our recommendation in our comments is that they need to refer to the labeling for a pump requirement. Honestly, that's not perfect either, and it does allow maybe for future drug approvals to kind of game the system and put the magic words in the prescribing information. But you know, that alone hasn't always been enough for them to add a drug to DME POS either. So they really didn't specify what criteria they would use to determine the need for a pump for these products. I would look at the prescribing information. If you go to the drugs website, there's always healthcare professional portals where they put the full prescribing information. You can download it as a PDF and search for the word pump. Someone was asking where to find the information. And that's not necessarily yet finalized. That's kind of how we started our search to say, because honestly, when you have a healthcare professional administering one-on-one with a patient, you most often aren't going to use a pump unless there's some need to. I know maybe in suites and centers, it's a little more standard to use a pump so a nurse can multitask and see more than one patient at a time, maybe. But in the home, I think there's a variety of administration methods that are used. Some might use a pump, some might not. So I think that is an open question.
Yeah, the need for a pump in the PI in the prescribing information is usually in the administration section. There's a dosing and administration section, and that's where they talk about how to administer and if there's a method of administration that's preferred or required.
And as we've reviewed some of the prescribing materials, there's lots of different language used. Some of them say you may use a pump or you may use other administration methods. And they have been very conservative in qualifying new products for DME POS, and a pump has been the kind of driving criteria, and the need for a pump generally has been reserved for things that require more of a continuous infusion or a longer infusion. So most of these products are 1 hour, maybe, couple hour infusions, not meeting that historical criteria for a pump. So again,
Right.
some need for them to clarify. The good thing is they didn't use discretion and just say, we're just gonna say anything that has an infusion rate of X is gonna require a pump. They could have done that and they did not do that. And we actually commended them for not doing that because the need for a pump is somewhat of a clinical decision based on the patient condition, the drug you're using, and some other clinical factors. And that's generally been a practitioner level decision. And that's actually where we prefer to keep it. But in this case, we need something more objective. And so the next best thing is to refer to the prescribing information. All right, I don't have any other questions in the Q&A. We again thank you for your time today. Watch for our final comments on the home health rule as well as the IPAI proposal. We will have comments on that as well. And appreciate everyone's time. Thank you and have a great day.